We are going to get tired of hearing my voice today. I'm not Dr. Herenga, I'm not Dr. Ndaguru. I'm Dr. Nyambura. Maybe it rhymes with Ndaguru. We continue with the talk on fibroids. This colleague will make it today for emergencies. So they send their apologies and they've requested that I present on their behalf. So I will try to do justice to the presentation. This is the outline of the presentation. We look at basic gynecology ultrasound scan, clinical presentation of fibroids, recognition and classification of fibroids, fibroids and fertility, fibroids in pregnancy, and the differentials. You realize most of the stuff in this presentation has already been covered, so we'll try and fly through. How should a gynecological scan be done? So there's an algorithm that you need to use. This is by the issue of which mode of scan should we do, transabdominal, transvaginal, or should we combine the two? So you realize the transabdominal scan is what most people are used to doing, is what's available, and in terms of the patient's comfort, sometimes they accept it better than the transvaginal. However, the clarity of the images may be not so good with transabdominal. So transvaginal becomes the better option, especially when the uterus is big, is small. Yeah. So there is a rating of which scan do we do indicated there. So for transabdominal scan, considerations include poor visualization of the adnexa, and you need a full blood. Transvaginal scan, you don't need a full bladder, and it may be limited in patients with big uteruses, and the adnexa muscle is out of field of view. So it's not very appropriate for women with huge uteruses. And then a combination of the two is rated 3. However, there's no coronal view, a coronal plane of view of the uterus. We need an empty bladder for that. And then transabdominal, transvaginal, which is rated at 4 classes if you include the 3D imaging. Is the perfect. Maybe the cost may be limiting. It also needs an empty bladder. So gynecological ultrasonography is often better performed through the transvaginal route. This provides a higher resolution. Transabdominal scan, however, may complement transvaginal scan when the pelvic organs are enlarged. So you may use the two together. So what is normal? This is a look at the normal dimensions of the uterus, normal dimensions of the ovaries. So you have a length of 6 to 10, width of 3 to 5, height of 3 to 4. We don't want to bother you too much with that. I think we had a nice talk on the basic science. Right. When you do the scan, the normal uterus will have a homogeneous echo texture. And the fallopian tubes may not be visualized, actually not visualized unless there's a pathology there. When you do the uterine artery Doppler, the pulsatility index should be less than 3 in a normal uterus. We also look at what we evaluate in terms of the ovaries and the endometrium. What is the purpose of ultrasound scan in evaluating fibroids? We want to explain the underlying symptoms. map the fibroids and plan for surgery. We want to stratify risk in women who are pregnant. Infertility causal evaluation. This is a very controversial topic. I think our next presentation will try and enlighten us more on that. What are the common presentations for patients with fibroids who are coming for evaluation with the ultrasound scan? So the majority of women with fibroids are asymptomatic. We talked about ranges of 60 to 80% in the morning. So these may be actually incidental findings. However, from the study by Zimmerman, there's a statistically significant difference in terms of bleeding in women who have fibroids compared to those who are coming for scan and do not have fibroid. With the p-value for most of the findings, they're less than 0.01. What are the risk factors for fibroids? We talked about this area in the day: genetic factors, race, the age, early menarche and late menopause, parity, so oligoparity, nulliparity, a higher risk of developing fibroids. Other factors include obesity, high blood pressure, caffeine and alcohol also include. The terms and definitions by T-Van. So looks at the definitions, measurements to be described during a scan for fibroids and uterine masses. This is how we then evaluate. So we get very good images when we are doing transvaginal scan, and you can clearly delineate the structure of the uterus from the serosa all the way to the endometrium. And if there are any intracavitary lesions, you may be able to pick them. However, when the uterus is large, it may be difficult to evaluate, and you may need to do a combination of scans. What are the steps that we follow? First, you want to identify the fibroid, measure the size of each fibroid that you note, its location, and the number of fibroids. Look at the appearance of the fibroids. Is there any evidence of degeneration? We look at vascularization. We can ever emphasize on this one because we also want to make sure there's no chance of malignancy. Infertility, if fertility is important for this patient, you need to assess the endometrium as well. What is the relationship between the fibroid and the endometrium? Is there any distortion of the endometrium? Look at the if the patient is pregnant, look at the placenta. Where is the location? Anterior, posterior, placenta previa, and look at the cavity of the uterus and the cervix. I will not bother you with that. We have already done the classification. What are the complications of fibroid? So you are going to look at this in a stepwise manner. The first, you want to look at the patient who is not pregnant, so non-pregnant patients. They will present with all the complications of heavy menstrual bleeding, chronic pelvic pain, and sometimes they may have history of subfertility as well. Then you look at the patient who has then conceived. Okay, before they even conceive, you look at what they've gone through to try and conceive. And then when they conceive, you also get those complications. Miscarriages being the major worry in the early trimesters. In the late trimesters, we also have issues to do with assessing or evaluating the gestational age. So when you look at the simplicity of our height, it becomes meaningless in a patient who has a fibroid uterus. So you really need then to make use of the ultrasound scan. Placentation may be abnormal. We talked about the placenta previa. They may also bleed during the pregnancy, so they have higher risk of APH. And then they go into labor. Because of the fibroids, they may actually have abnormal presentations of the babies, delayed progress of labor. So because of uterine atony, the labor may become prolonged. When they deliver, they may have protracted deliveries. And we may end up resorting to emergent cesarean section. Post-delivery, they also have the issue of PPH. This is what this image is showing us. Treatment, I think we have gone through the medical treatment for fibroids. Very pertinent when the woman is pregnant. What do we give? What do we use to reduce the pain? I think we had quite a nice discussion in terms of what do we do to reduce the pain during pregnancy. So this study here is looking at what are the options. Tranexamic acid is not going to reduce the size, it just reduces bleeding, but it's not contraindicated in pregnancy, save for the patients who have a VTE or history of previous VTE. Mefenamic acid for pain, it's neither here or there. So you individualize the patient if you want to use the non-steroidal anti-inflammatory agents. Uterine artery embolization. Very, very important topic. What is the effect of uterine artery embolization in pregnancy? So these are patients who have gone through embolization and then they conceive. What are the effects to these women? So this study here by Woma 2010 was trying to look at what will happen to the woman who has had uterine artery embolization in pregnancy. So they looked at the risk of miscarriage. Women who had UAE had a risk of 35.2% of miscarriage, compared to controls who had a risk of 15% of miscarriage, those that had not gone through UAE. And this was statistically significant. Other findings that were statistically significant were an increase in the cesarean section rate and increase in PPH following uterine artery embolization before pregnancy. There were no statistically significant differences in fetal growth restriction, birth weight, preterm labor, and malpresentation. This is a study that was designed to look at the effects on pregnancy and neonatal outcomes in women who had fibroid pregnancy. They looked at a total of 12,855 women. When postpartum hemoglobin levels for the control group and fibroid group without myomectomy were compared, hemoglobin levels were higher in favor of the control group. The appearance of fibroids on imaging. This is a transvaginal ultrasound scan. Even on transabdominal ultrasound scan, you can be able to distinguish normal myometra from fibroids. And the appearance are wide-ranging. It can be hypoechoic, isoechoic, hyperechoic, mixed echogenicity. And sometimes they can be very echogenic, especially when the fibroids, there's calcific degeneration. And can be cystic if there's cystic degeneration. And we went to town in terms of discussing vascularity of uterine tumors. I think it's very important that you do Doppler interrogation every time you see a pelvic mass, not just the measurement. What are the effects of fibroids on the pregnancy? So I think we've gone through this. It looks at the first trimester, higher risk of miscarriages. Going to the mid trimester, abnormal placentation, risk of antepartum hemorrhage, risk of placenta abruption. You go into the third trimester, difficulties with evaluation of gestational age. Delivery, we talked about difficulties in the delivery and maybe the need to have emergency cesarean section. And also the risk of PPH secondary to uterine atony in an over-distended uterus. And it's a repetition of what we've just been describing. Preconception, early pregnancy, and then it's 20 to 22 weeks. We continue mapping. We do the anatomy scan. You stratify risk pregnancy of the pregnancy loss. Yeah, and then you assess growth. We said it's very difficult to use this of under height in women with fibroid. So the scan will do justice to these women, and you then need to plan for delivery in a setting where you can resort to cesarean section if labor does not progress from. So there's the issue of myomectomy at C-section. We're going to talk about this in a few slides. Postnatal reduced or increased time to involution. So the uterus remains big for a longer time compared to the non-fibroid uterus. So move the slides on. All right, I think this is my case. Antenatal myomectomy. When are they indicated? In a patient who has a painful degeneration of fibroids, large fibroids greater than 5 centimeters in the lower segment, rapidly growing fibroids with torsion. So patients with complicated fibroids, you may be forced to do antenatal myomectomy. It's not indicated unless there's an emergency. Ideally, it should be done after the first trimester or in the second trimester. Very difficult to do it in the third trimester because of vascularity. And then this is a study by Molika in 1996, which was comparing the outcomes of women with fibroids who did not undergo myomectomy compared to those who had myomectomy. And you realize that contrary to what we have been taught or what we have read or previous studies, this study is actually showing that there may be benefits in doing myomectomy even in the antenatal period. And women who had myomectomy had 0% miscarriage. So they looked at 18 patients, 0% of miscarriage rate. And 12 out of the 18 had miscarriages in the women who did not undergo myomectomy, which was 13.8%. A lower risk of people, lower risk of fetal growth restriction, preterm delivery in patients that had myomectomy. However, there's a higher risk of cesarean section in patients who had myomectomy antenatal for obvious reasons, one of uterine rupture, one of antepartum hemorrhage for bleeding and abruption placenta. All right, next slide, please. In terms of the, you can go back to the last slide. In terms of the fetal outcomes, you realize there is not much difference in the APGAR scores and breakdowns. And we can go to the next one. Myomectomy and cesarean section. There was a talk on this one earlier again. What are the indications? Fibroids causing difficulty with closure of the uterus. So if the uterus is lying in the lower segment and you are failing to close the uterus, the teaching is just go around the fibroid. Don't go through the fibroid, but sometimes you may inadvertently go through it. So if you can't close the uterus, then you may be forced to do myomectomy at C-section. It may be necessary to do it to facilitate delivery of the baby or even the placenta. For instance, the patient who was presented from Botswana area in the morning, who had a stuck placenta which was morbidly stuck in the uterus because of the fibroid. The moment the fibroid was removed, the placenta just fell out. So you may be forced to do myomectomy C-section in such case. Light fibroids greater than 6 centimeters in diameter, visible subserosal fibroids. However, do not be tempted to willy-nilly do myomectomies in pregnancy at C-section because we have had a number of women dying because of that. High vascularity, risk of bleeding from the incision, and risk of even failing to achieve hemostasis, ending up removing the uterus or even losing the woman. So it should be justified. Next slide, please. So the best mode of delivery for any woman is by a normal vaginal delivery, unless there are contraindications. Fibroids in pregnancy is not equal to cesarean section. Only do C-section when indicated. However, we know that the fibroids may actually obstruct. If you are in the lower segment and obstructive, you may result to C-section. And they may cause fetal malpresentation, and breech presentation, transverse presentation. Okay. Patients with the subserosal fibroids fare better in terms of vaginal delivery, but you should be wary of uterine artery during the labor itself, which tends to protract the labor, and then uterine artery predisposing to PPH post-delivery. Those are just images. You can go to the next one. Again, just what you're going to find when you do scans in patients with fibroids. Thank you for listening.